No quisiera hablar, pero tú eres la frase de amor empezada y nunca terminada.
No cambiarás, no cambiarás, no cambiarás.
Tú eres mi ayer y mi hoy.
Nunca más.
Mi siempre y mi inquietud.
Y ya que tú estás en ello, llámame tormento ya. Puedes probar.
Tú eres como el viento que lleva los violines y las rosas.
Caramelo, no los quiero más.
Algunas veces no te comprendo.
Violines y rosas, esta noche lo dices a otra. Violín y rosa, yo quiero sentirla. Cuando la cosa me va, si es el momento y luego se verá.
Una palabra todavía.
Palabras, palabras, palabras.
Escúchame.
Palabras, palabras, palabras.
Te ruego.
Palabras, palabras, palabras.
Yo te juro.
Palabras, palabras, palabras, palabras. Tú siempre me dices palabras, palabras de amor.
Este es mi destino. Hablarte como la primera vez.
Siempre igual, tú siempre igual, tú siempre igual.
No digas nada, es la noche que habla.
Siempre igual.
La romántica noche.
No cambiarás, no cambiarás, no cambiarás.
Tú eres mi sueño prohibido.
Nunca más.
Pero tengo esperanza.
Y nadie a ti podrá pararte. Llámame pasión al fin, dímelo ya.
Se apaga en tus ojos la luna y se escuchan los grillos.
Caramelos, no los quiero más.
Si tú no existieras, necesitaría inventar.
La luna y los grillos normalmente me tienen despierta, mientras yo quiero soñar con el hombre ese que tú llevas dentro de ti, que habla menos, pero me gusta a mí.
Una palabra todavía.
Palabras, palabras, palabras.
Escúchame.
Palabras, palabras, palabras.
Te lo ruego.
Palabras, palabras, palabras.
Yo te juro.
Palabras, palabras, palabras, palabras. Tú siempre me dices palabras, palabras de amor.
¿Cómo eres?
Palabras, palabras, palabras.
Pero ¿cómo eres?
Palabras, palabras, palabras.
¡Qué mujer!
Palabras, palabras, palabras.
¿Cómo eres?
Palabras, palabras, palabras. Tú siempre me dices palabras, palabras. La
Sayın Rektörüm, Rektör Yardımcılarım, Sayın Dekanım, değerli hocalarım, idari personellerimiz ve çok sevgili öğrenciler. Bir ustanın izinde Doktor DeFronzo ile Diyabetin Geleceği başlıklı seminerimize hepiniz hoş geldiniz. Honorable Chairman of the Board of the Trustees of Atlas University, esteemed Rector, Vice Rectors, Honorable Dean, distinguished professor, administrative staff, and our dear students. Welcome to our seminar titled In the Footsteps of a Master, The Future of Diabetes with Dr. DeFronzo. Today, we have gathering here to listen pioneering studies of Dr. Ralph DeFronzo in the field of diabetes and to explore together how its work continue to illuminate the future of medical science. Bugün burada Dr. Ralph DeFronzo'nun diyabet alanındaki öncü nitelikli çalışmalarını dinlemek ve bu çalışmaların geleceğe ışık tutan yönlerini birlikte öğrenmek üzere bir aradayız. Şimdi programımızın akışına bir göz atalım. İlk olarak Dr. Ralph DeFronzo'nun güçlü akademik ve uzun bir geçmişi, bilime yön veren çalışmalarını birlikte inceleyeceğiz. Ardından Sayın Rektörümüzün açılış konuşmalarını dinleyeceğiz. Rektörümüzün konuşmasından sonra Dr. DeFronzo'nun bizlerle kendi sunumunu paylaşacak. Bu oturumun devamında plaket ve çiçek takdimlerini gerçekleştireceğiz. Ardından kısa bir aradan sonra seminerimiz bilimsel çalışma gruplarının tartışmaları ve değerlendirmeleriyle devam edecektir. Now let's brief review to outline our program. We will begin with the overview, the Dr. Ralph DeFronzo distinguished academic background and his influential contributions to medical research. Following that, we will listen to the opening remarks by our esteemed rector. After the rector address, Dr. DeFronzo will deliver the presentation. The session will then continue with the presentation of plaquettes and flowers. After a short break, our seminar will proceed with the discussions and evaluation of the scientific working group. Şimdi diyabet alanlarında çığır açan çalışmalarıyla dünyada derin izler bırakan Dr. Ralph DeFronzo'nun başarılarla dolu özgeçmişini size takdim etmek istiyorum. Dr. Ralph DeFronzo, Yale Üniversitesi'nden biyoloji ve biyokimya bölümlerinden ve Harvard Üniversitesi Tıp Fakültesinden mezun oldu. John Hopkins'te dahiliye eğitiminin ardından endokrinoloji ve nefroloji alanlarında uzmanlığını tamamlamıştır. Dr. DeFronzo 1988 yılından beri San Antonio'daki Texas Üniversitesi Long School of Medicine'da diyabet alanında Joe and Teresa Lozano seçkin kürsü başkanlığını sürdürmektedir. Dr. DeFronzo son 50 yıl içerisinde diyabetle ilgili pek çok önemli gelişmenin de önde gelen ismidir. İnsülin direnci kavramını geliştirmekte öncü bir rol oynamış ve bu kavram tip 2 diyabetin tamamlayıcı özelliği haline gelmiştir. Bu da diyabetin gelişimi ve ilerlemesi yolunda yeni fikirler ortaya çıkartmıştır. Dr. Ralph DeFronzo, Metformin adlı ilk basamak diyabet tedavisi ilacının Amerika'daki gelişimini yönetmiş ve FDA onayını 1995 yılında almıştır. Böbreklerde glikoz geri emilimini hedefleyen diyabet tedavisi için yeni bir yaklaşım keşfetmiş, bu çalışma depaglikozin gibi yaygın olarak kullanılan diğer ilaçların geliştirilmesine ve onaylanmasına olanak sağlamıştır. Diyabet araştırmalarının dünyada önde gelen figürü olan Dr. DeFronzo, hakemli dergilerde 800'den fazla yayının yazarıdır ve Diyabet Mellitus'un uluslararası ders kitabının editörüdür. Oliglisemik insülin klempleme tekniğinin radyoizotop dönüşüm metodolojisi, uzuv katetrasyonu, endirekt kilometri ve kas biyopsisi ile birleştirerek tip 2 diyabet mellitus'taki insülin direncinden sorumlu biyokimyasal ve moleküler bozuklukları tanımlamaya da yardımcı olmuştur. Dr. DeFronzo'nun bilimsel çalışmalarıyla yalnızca diyabet alanında değil, aynı zamanda pek çok genç araştırmacının yetiştirilmesine büyük katkı sağlamıştır. Bu olağanüstü katkıları yıllar içerisinde birçok saygın kurum tarafından da ödüllendirilmiştir. Şimdi ödüllerine biraz göz atalım. 1987 yılında Amerikan Diyabet Derneği tarafından genç araştırmacı olarak öne çıktığı için Lilly ödülüne layık görülmüştür. 2002 yılında yine Amerikan Diyabet Derneği 200'den fazla genç diyabet araştırmacısının eğitilmesine katkılarından dolayı Albert Reinhardt ödülü ile onurlandırılmıştır. 2005 yılında Amerikan Diyabet Derneği'nin yıllık bilimsel toplantısında dünya çapında en önemli klinik araştırmacı olarak Novartis ödülünü almıştır. 2008 yılında yine Amerikan Diyabet Derneği'ne verilen Banking ödülünün ve Avrupa Diyabet Araştırma Derneği tarafından verilen Claude Bernard ödülünün de sahibi olmuştur. Ve son olarak 2017 yılında Amerikan Diyabet Derneği ve Avrupa Diyabet Araştırma Derneği tarafından ortaklaşa verilen Harold Hamm Diyabet Biomedical Araştırmalı Uluslararası Ödülü ile onurlandırılmıştır. Bu ödüller DeFronzo'nun diyabet araştırmalarındaki öncü katkılarının ve bilim dünyasına ilham veren kariyerin göstergesidir. And now, it's a great pleasure to introduce the groundbreaking work and outstanding academic journey of Dr. Ralph DeFronzo, true pioneer in the field of diabetes research. Dr. Ralph DeFronzo received his undergraduate degree, biology and biochemistry, with um, Yale University and his medical degree from Harvard Medical School. Following his education in internal medicine, Johns Hopkins, he completed his proficiency in endocrinology and nephrology since 1988. Dr. DeFronzo has held a chair in the Joe and Teresa Lozano in diabetes and at the University of Texas Long School of Medicine, San Antonio. Dr. DeFronzo has been a leading figure in many important developments related to diabetes over the past 50 years. He played pioneering roles in developing the concept of insulin resistance, which has become defining feature to type 2 diabetes. This has led to new ideas about the development and progression of diabetes. Dr. Ralph DeFronzo and estimated the development of metformin, the first-line diabetes treatment drug in the United States, of obtained FDA approval in 1995. He pioneered a new approach to diabetes treatment targeting glucose reabsorption in the kidneys, which led to development and approval of other widely used drugs such as dapagliflozin. Dr. DeFronzo, a leading figure in diabetes research worldwide, is the author of the over 800 publications in peer-reviewed journals and is the editor of the International Textbook of Diabetes Mellitus. Dr. Rock DeFronzo's main areas to expertise are pathogenesis and treatment of type 2 diabetes mellitus and metabolic cardiovascular disorder known as insulin resistance. Dr. DeFronzo's primary research interests focus on the pathogenesis and treatment type 2 diabetes mellitus as well as metabolic and cardiovascular disorder associated with insulin resistance, the radioisotope conversion methodology of euglemic insulin clamping technique, combined with line characterization, indirect calorimetry, and muscle biopsy, has helped identify the biochemical and molecular abnormalities responsible for insulin resistance in type 2 diabetes mellitus. Throughout his remarkable career, Dr. DeFronzo has not only our understanding of diabetes, but has also mentored and inspired hundreds of young scientists around the world. His outstanding contributions have been recognized by numerous international organizations. In 1987, he received the Lilly Award from American Diabetes Association as an outstanding young investigator. In 2002, the American Diabetes Association him with the Albert Reynolds Award for his exceptional dedication to training and mentoring over 200 young diabetes researchers. In 2005, at the ADA annual scientific session, he was recognized as the world's leading clinical investigator in diabetes and received the Novartis Award. In 2008, he was awarded the Banting Medal for Scientific Achievement by the ADA and the Claude Bernard Award by European Association for the Study of Diabetes. And finally, 2018, 17, he received one of the most prestigious honors in the field, the Harold Hamm International Prize for the Biomedical Research in Diabetes, jointly awarded by the ADA and EHSE. These awards stand as a testament to Dr. DeFronzo's pioneering impact on diabetes research and his lifelong dedication to advancing medical science. Şimdi programımızın açılış konuşmasını yapmak üzere İstanbul Atlas Üniversitesi Sayın Profesör Doktor Ersoy Kocabıçak'ı sahneye davet ediyorum. Now I would like to invite the stage director İstanbul Atlas University to deliver opening remarks.
Üniversitemizin değerli yöneticileri, değerli akademisyenlerimiz, sevgili öğrenciler ve değerli konuklar, bugün tıp bilimi için, bilim dünyası için çok özel, çok müstesna bir ismi buluşlarıyla diyabet tedavisinde çığır açmış bir bilim insanını ağırlamanın büyük bir memnuniyetini duyuyoruz Atlas Üniversitesi olarak. Hepinize hoş geldiniz diyorum. Sevgiyle, saygıyla selamlıyorum arkadaşlar. Dear Professor DeFronzo, we are very happy, great pleasure to host you here in this auditorium named your honor. Evet, sevgili misafirler, sevgili hocalarım, biraz önce söylediğim gibi hakikaten çok özel bir insanla bir aradayız. Bilim insanlarının ya da keşif yapan insanların en büyük özelliğinin zeka olduğu düşünülür. Bir bakıma belki de doğrudur bu. Bununla beraber başka parametreler de var elbette bu başarı için. Herhalde bunların başında da merak duygusu geliyor. Merak olmadan bilimsel bir keşif yapmak neredeyse imkansız. Tabii bu merakı bilimin sistematize edilmiş yollarıyla geçerek başarıya ulaştırmak mümkün. Ve bunun dışında da tabii ki dirençli ve sabırlı olmak. Bu yolda ilerleyebilmek. Tabii bu salonda olan hemen herkes zaten hayatında bu yolların en azından bir kısmını yürümüş vaziyette. Özellikle sevgili gençler ve çiçeği burnunda sevgili akademisyenler. Sizlere belki ufak bir iki şey daha söylemek istiyorum. Gerçi öğüt zamanında taze yenmemiş bir ekmeği başkasına bayat yedirme denemesi derler ama biz de yine bir şeyler yapmış olduk kendi bilim yolculuğumuzda. Şimdi Einstein'a atfedilen bir anekdot var. Ben bunu çok seviyorum ve paylaşıyorum da. Einstein'a diyorlar ki, ya siz çok zeki olduğunuz için herhalde bu kadar başarı elde ettiniz. Onun cevabı çok bence ders niteliğinde. Diyor ki, hayır, çok zeki olduğum için değil. Bence dirençli ve sabırlı olduğum için buralara geldim. Ve şöyle diyor, bir mektup kutu gibi olun ve varacağınız adrese ulaşmadan ondan ayrılmayın. Aslında başarının belki de hakikaten en büyük parametresi bu. O yüzden aslında şöyle demek çok mümkün. Hayal ettiklerimiz, yapabileceklerimiz, daha doğrusu hayal ettiklerimiz de sınırlı. Bunu söylemek istiyorum ben. Ve hepinize eğitim hayatınızda başarılar diliyorum. Ve tabii son olarak yine Sayın DeFronzo'ya hoş geldiniz diyorum. Sözü de burada bırakmak istiyorum. Hepinizi sevgiyle, saygıyla tekrar selamlıyorum.
Değerli konuşmaları için teşekkür ederiz. We sincerely thank our rector for his valuable speech. Şimdi diyabet araştırmalarına yön veren katkılarıyla tıp dünyasında derin bir saygı uyandıran değerli bilim insanı Dr. Ralph DeFronzo'yu alkışlarınızla sahneye davet etmekten büyük bir mutluluk duyuyorum. Now it's my great pleasure to invite to the stage Dr. Ralph DeFronzo and distinguished scientist who has shaped the field's diabetes research with his pioneering contributions. Please welcome him. Welcome with your warm applause.
Okay, it's a great pleasure to be back here in Istanbul. I think this is like the 4th year in a row. So now I feel very comfortable. I have many friends. I look forward to continue to come back in the future. And I know Professor Kanat has recently agreed to leave from the States and come over and join the faculty here. So we look forward to continue our research activities as we go forward. So today I'm going to talk about type 2 diabetes. It's a problem everywhere in the world. Doesn't make any difference where you go. It's a huge problem, and it's a ever-expanding problem. And what I am going to try to do is to start really at the root of the disease. So if you understand what causes a disease, you understand the pathophysiology, you'll be very, I think, well equipped to learn how to treat the disease. Unfortunately, many of you use one drug and you don't know what it really is doing. You add a second drug, and the net result is the diabetic patient doesn't get controlled very well. But I've spent most of my life trying to define what causes this disease and then to develop medications that will reverse the basic etiologic problems. And if you do that, and if you use drugs in combination, you actually can get people with type 2 diabetes in very good control, and you can prevent the macrovascular, the heart attack, stroke complications that are the devastating part of this disease. So when I gave the Lilly lecture, which is the Young Investigator Award at the American Diabetes Association, I simply called it the triumvirate. 3 problems that we have to deal with, okay? And the lower left is the liver. We'll talk about these in a little bit more detail. And the bottom right is the muscle. And at the top is the beta cell. So we go to sleep at night. Our fasting glucose is 80. And you wake up in the morning and your fasting glucose is still 80. How does that happen? You haven't eaten anything. So how can you possibly keep your blood sugar constant at 80 milligrams per deciliter? Well, while you're asleep, the liver produces glucose at a constant rate, and it keeps your blood sugar at about 80 milligrams per deciliter. The person with type 2 diabetes, their liver is very, very resistant to insulin. And so throughout the sleeping hours, the liver of the person with type 2 diabetes overproduces glucose. And so when the diabetic patient wakes up in the morning and they have an elevated fasting glucose, that's all due to excessive hepatic glucose production. So clearly we're going to need medications that work on the liver to shut down hepatic glucose production. So now the diabetic wakes up in the morning and the fasting glucose is elevated. They're going to have their breakfast and then they're going to have the lunch and the dinner. And the carbohydrates in the meal, the glucose, needs to be taken up and disposed of in the muscle. Now, because the muscle is resistant to insulin, you get post-meal and post-prandial hypoglycemia. And then the third component is the beta cell. And we know that there are a number of genetic abnormalities that contribute to beta cell failure. And as the diabetic goes through life, it's progressive based failure in the presence of severe insulin resistance that leads to marked hyperglycemia. So in 1987, this was a pretty simplistic understanding of what caused type 2 diabetes. 3 problems, should be easy to treat. Wrong. So in 2008, when I gave the 2008 when I gave the Banting lecture, which was the Lifetime Scientific Achievement Award at the ADA, I called it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So we had no longer 3 problems to deal with, we had 8 problems to deal with. So, of course, in the lower left, we still have the insulin resistance in the muscle, in the liver. The lower right, we still have the insulin resistance in the liver. And then at the top of the left, we have the beta cell. So what are the other 5 players? So let's start in the upper right with the fat cell. What's driving the epidemic of diabetes today is the epidemic of obesity. We take in excess calories, and as long as those calories are stored in the fat cell, they can't hurt you. But as the fat cells start to expand, the fat cells become very, very resistant to insulin. And now you start to break down the triglycerides that are in the fat cells, and you release FFA into the bloodstream. And we don't, in clinical practice, normally measure the plasma FFA levels. But if you were to measure the plasma FFA levels in people with diabetes, you would find that they're very elevated. So what's the problem with that? The elevated FFA interfere with insulin secretion, and they cause insulin resistance in the liver, and they cause insulin resistance in the muscle. So this defect in the adipocyte is exacerbating 3 basic causes that are involved in the pathophysiology of type 2 diabetes. So at the top is the gastrointestinal tract. And when you eat a meal, you release 2 incretin hormones. One is GLP-1, glucagon-like peptide 1, and the other is called GIP, glucose-independent polytropic hormone. This GIP and GLP incretin hormone account for 70% of the insulin that you release in response to a meal. So what goes wrong in the gut pattern? Is it that you don't make enough GLP-1 or GIP? That's not the answer. It's at the level of the beta cells. Your beta cells have become very resistant to GLP-1 and GIP. And of course, we have a treatment for that using these new GLP-1 receptor agonists. And I'm going to give you a pharmacologic dose of, could be Mounjaro, etc. We'll come back and talk about them. I can overcome that GLP-1 GIP resistance, and I can then drive insulin secretion. At the level of the alpha cells, we know that the alpha cell hyperproduces glucagon. And those elevated glucagon levels drive hepatic glucose production throughout sleeping hours and contribute to the reason why a diabetic, when they wake up in the morning, have an elevated fasting glucose concentration. At the level of the kidney, we also know that there's a major problem. So the diabetic has an elevated fasting glucose, and because of that, they're going to filter more glucose. But unfortunately, that glucose, which is filtered by the kidneys, does not end up in the urine because there's an upregulator of a particular transporter called the SGLT2 transporter. And that upregulation of the SGLT2 transporter holds on excessively to the amount of glucose which is filtered. And as was indicated, I actually developed the drug, the SGLT2 inhibitor, that blocks that transporter, and this class of drugs now has been shown to be very effective in treating people with type 2 diabetes, and we'll come back and talk about that in a lot more detail. And then at the bottom is the brain. So the brain plays a very important role in the pathophysiology of diabetes, but in a very, very different way. So in these hedonic areas of the brain, there's been a marked disruption of the neural circuitry. So that when some individuals look at food, food looks more appealing. And therefore, they overeat, they take in excess calories. In my opinion, the people who are working in the obesity field do not understand at all what is the cause of obesity. They've been focusing on the hypothalamus. And that's really not what the problem is. The problem is in the prefrontal cortex, the amygdala, the caudate, and these areas. There's a marked decrease in the brain-gray matter area, and the neurocircuitry has become quite disrupted. And because of that, people overeat. I'm not going to talk about transcranial magnetic stimulation, but we've developed a new technique where a person sits in a hat that has magnetic coils, and we actually magnetize the brain. And it turns out that this is a very, very effective way of treating obesity. And I think it's for the future, maybe next year when I come, I will talk about this. And I know that there's at least one person here who's interested in, he's just come back from Colombia, and he's interested in the brain and neuropsychiatric diseases, Alzheimer's, but it goes hand in hand with obesity and diabetes. So when you look at this problem, we have 8 totally different pathophysiologic disturbances. So why do you think that one drug can correct 8 problems? It's not going to happen. We need to be thinking about combination therapy with drugs right from the beginning to correct multiple problems if we want to get our diabetic control. And so what I'm going to do today is I'm going to take you through the drugs that are available, and then I'm going to match them up with the ominous octet and show you where they work. So, as I said, if we start now to think about the treatment of type 2 diabetes, no one drug is going to control the glycemia. You're going to have to be using drugs that work in complementary ways together. We also should pick a drug that corrects the underlying pathophysiology. There are some drugs like sulfonylurea. They'll lower the A1C and the glucose, but they don't correct the underlying problem. And obviously, in a long-term basis, that kind of approach is not going to work. And then the last thing is we need to start very early in the natural history of the disease. Because if you start to lose beta cells, eventually you're going to end up on insulin therapy. And insulin therapy is very, very difficult for people with type 2 diabetes. So again, critically important that we start early. We start with the drugs that correct the underlying pathophysiology, and particularly the drugs that correct the insulin resistance in the beta cell cells. So this is a study that was performed many, many years ago by Dr. Robert Turner, a very good friend of mine in England. And at this time, there was a lot of controversy in the diabetes field as to whether controlling the glucose actually had any impact whatsoever in preventing the microvascular complications. So some people, half of the people in the world, believe that the eye, the kidney, and the nerve damage was all genetically determined. And it didn't make any difference how well you control the glucose, you're still going to end up with diabetic retinopathy or diabetic kidney disease. So this is the very first study in people with type 2 diabetes, and I think it's important to understand the history that this is a landmark study that showed for the first time that good glycemic control was important. So Dr. Turner believes that if you take newly diagnosed type 2 diabetic patients, they started here with an A1C of 7, and he's going to put them on one of 3 interventions. 1/3 of the group in yellow got diet and exercise. As you can see by the yellow curve, it grows straight. There was actually, in terms of the A1C, a progressive rise. This was all due to progressive beta cell failure. Okay, so diet and exercise really didn't work that well, and I can tell you in 2025, diet and exercise still doesn't work that well. Okay, we try, we lose weight, we gain weight, we lose weight, we gain weight. The net result is we don't usually do such a good job. The next drug that they use is glibenclamide. It's sulfonylurea. It binds to the sulfonylurea receptor. It kicks out insulin. The insulin initially overcomes the insulin resistance. And you can see there's a nice drop in the A1C. But look what happens to the A1C rises progressively over time. He showed that all of that rise in the A1C was due to progressive beta cell failure. The third drug that he used was metformin. That's in orange. Metformin is not a true insulin sensitizing drug. I know many medical students are taught that. Metformin works on the liver to shut down hepatic glucose production throughout the sleeping hours. As you can see, there is a nice drop initially in the A1C, but a progressive rise in the A1C, again, because of progressive beta cell failure. So Dr. Turner noted that 5 years into the UK PBS study, the A1C had come back to baseline. So he published 5 papers, and he said, my hypothesis is not correct in diabetes, diabetes care, diabetologia, DMJ, and Lancet. He said you cannot put people with type 2 diabetes on a single oral agent, bring the A1C down, and keep it down. So what he said, I need to change the design of the study. So 5 years into the study, if you're on metformin, he added glybenclamide. If you're on glybenclamide, he added metformin. And then he also said, if I need insulin, I will also add insulin. As you can see now, 15 years into the study, everybody is on glybenclamide and metformin. 65% of the people are on insulin. And if you were to read across, the A1C is 8.8. This is a total, absolute failure. Okay? I don't think anybody in this audience would want this kind of treatment. This is guaranteed you're going to end up blind, end up with kidney failure, or peripheral neuropathy. Okay? So we've known this now forever and ever and ever. What is the number one drug sold in the world? Metformin. What's the number one drug sold in Istanbul? Metformin. What's the number 2 drug sold in the world? Sulfonylurea. Number 2 drug sold in Istanbul, sulfonylurea. And believe me, it's exactly the same in the U.S. So we didn't learn anything from this study in terms of the drug. So what did we learn? We learned that there was a 1% separation between the control group and the treatment group, and that led to a 37% decrease in eye, kidney, and nerve complications. So this is the landmark study that says good glycemic control or improved glycemic control makes a difference in preventing eye, nerve, and kidney damage. But it also told us what drugs would not work. So, have we learned from this study? And the answer is no. Okay? So, how many of you are familiar with the GRADE study? Yeah, no one. 1, 2, 3, yeah, okay? So this is another classic study, and you all should be very familiar with it. This is a recent study carried out by the National Institutes of Health. And in this study, what they wanted to know is that if you were on metformin, you had failed. So to get into this study, you had to be a failure on metformin. You had to be on metformin, had an A1C above 7.5. Okay. What was the best drug to add to metformin? So you could add glybenclamide, a sulfonylurea. You could add sitagliptin, a DPP-4 inhibitor. We'll talk about that for a minute. You could add liraglutide, a GLP-1 receptor agonist, or you could add glargine insulin. And look what happens. There's an initial decline, and then thereafter, a continuous rise. So what this study showed is exactly what Dr. Turner showed 30 years ago. We didn't learn anything. We decided, well, in 30 years, diabetes was going to change. Wrong. Okay? So the same drugs that didn't work 30 years ago still do not work. And what's the number 1 drug in the world still today? Metformin. Number 2 drug, sulfonylurea. Okay? Number 3 drug, DPP-4 inhibitor. You know what this says? We haven't learned a goddamn thing. Okay? Despite all of the science, we keep using the old drugs that don't work. Okay? Now, the surprising one to me was liraglutide. I really thought that the GLP-1 receptor drug, liraglutide, would work and be very effective, but it didn't. But I'm going to show you, however, that the newer GLP-1 receptor drugs, unlike liraglutide, actually do work and are very effective. So now, if we were to come back to the ominous octet, and we were to put, where do the cell-following alleles work? They do work on the beta cell, but they work only for a short period of time. After 6 to 12 months, their ability to continuously augment insulin secretion wears off. Metformin, it works here on the liver and cuts down hepatoglucose. So I brought metformin to the United States in 1995. It's a very, very good drug, but it's number 4 you'll see on my list of good drugs as I take you through this, okay? Now, this is a very, very different picture. These are the 8 studies that have been carried out for thiazolidine diamine. And we have 2 types of thiazolidine diamine, rosiglitazone and thiolglitazone. And what you can see is that the initial drops with thiolglitazone or rosiglitazone vary, because the study designs are very different. But whatever the initial drop is, you can see that the A1C comes down and it stays down. This is very different from what I showed you with cell-flowing ureas and metformin. So why is it that these DVs are so effective? Because they do 2 things. They are great insulin sensitizing drugs. The thiazolidine diones are the only class of insulin sensitizing drugs that we have. They work through the PPAR gamma system. And we, many years ago, developed a technique called the insulin clamp technique. This is the gold standard technique for measuring insulin sensitivity. So we're going to infuse insulin, and then with radio-labeled glucose, we can precisely quantitate how much the muscle in the body takes up and disposes of the glucose. And so this is before going on thiolglitazone in yellow, and before going on rosiglitazone in green. As you can see, the units are not so important, but there are milligrams of glucose metabolized per kilogram body weight per minute. There's about a 40% improvement in insulin sensitivity. So the thiazolidine diones are excellent insulin sensitizing drugs. They are the only class of insulin sensitizing drugs that we have. But the reason why these drugs are so good is because they also have a huge effect on the beta cell. So, how do you measure beta cell function? On a day, the patients will come in, and we're going to do an oral glucose tolerance test. And we're going to look at the insulin secretion rate by measuring C-peptide, the increment or incremental glucose. So this gives us an index of how much insulin the body is making during the OGTT. And on a separate day, we do that insulin clamp and we measure their insulin resistance. The gold standard for beta cell function is the amount of insulin that is secreted during the OGTT divided by how insulin resistant you are. And what you can see, if I treat you with placebo, your beta cell function doesn't change. If I treat you with thiolglitazone or rosiglitazone, I triple your beta cell function. So the real reason why the CBDs are so good is because they are both insulin sensitizers and they have a big effect on your beta cells. And in the United States, these drugs are $5 a month. So they're quite inexpensive, and they're also very inexpensive here in Turkey. So if we come back now to the ominous octet, the TZDs are a great insulin sensitizer in the liver, in the muscles, and the fat cells, and they markedly improve beta cell function. Since they correct 4 of the problems in the ominous octet, they're going to be a really very effective drug for treating people with type 2 diabetes. Now, what about cardiovascular disease? So diabetics get 2 types of complications. What we refer to as the microvascular complications, the eye problem, diabetic retinopathy, they go blind. The kidney problem, they end up in dialysis, neuropathy. The other kind of problems they get are what we call the macrovascular complications. They get heart attacks, strokes, peripheral vascular disease. So, the PROACTIVE study is a big study carried out in Europe, 5,276 individuals. These people all had a previous myocardial infarction, stroke, some kind of cardiovascular event. And they're going to be randomized either to placebo or to thiolglitazone. So what happens in this study? This is a Kaplan-Meier plot to the MACE endpoint. MACE endpoint stands for Major Adverse Cardiovascular Event. In order to get a drug approved in the United States by the FDA, you have to show benefit on the MACE endpoint. This is pretty much true everywhere in the world. As you can see here, time to death, MI, or stroke, the hazard ratio is 0.84. There was a 16% decrease in this composite cardiovascular endpoint. So pioglitazone is a very, very effective drug, not only for lowering the glucose and preventing the microvascular complications, but also for preventing the macrovascular complications. Now, what about the incretin class of drugs? So this is the newest class of drugs that have been introduced for the treatment of people in the United States. And there are two of them, GLP-1, glucosidase peptide 1, and glucose-dependent insulin-trophic polypeptide. These two incretin hormones, as I pointed out to you earlier, they account for 70% of the insulin that you release in response to a meal. So it's critically important that this axis be maintained. Now, as I said, the problem is not that you don't make enough GLP-1 on GIP. The problem is your beta cells are very refractory to GLP-1 and GIP. So I can treat the diabetic patient by giving them a very high dose of the GLP-1 and GIP. And in fact, we have a whole bunch of these drugs now that have been developed. So how do these drugs work? So the GLP-1 comes from the L cells down in the distal part of the small body. The GIP comes from the K cell. And when you eat a meal, there are reflexes to go from the stomach to the brain, back to the K and the L cells. And you very quickly release GLP-1 and GIP. And these two incretins are powerful, powerful augmenters of insulin secretion. Now, GIP has no effect on glucagon. GLP-1 has a big effect on glucagon. So when these drugs were developed, the pharmaceutical companies initially started to develop GLP-1 because it affected both insulin and glucagon. So these drugs are very, very powerful insulin secretagogues. And this is the major reason why they were developed. And they have phenomenal effect to increase insulin secretion. But what we've learned, they work on the brain to shut off your appetite. They're the best drugs we have for weight loss. They work on your heart to prevent atherosclerotic cardiovascular complications. And they also work on your kidney to protect you against diabetic kidney disease. So this is a phenomenal class of drugs. And as you'll see as I take you through this, this is now the recommended class of drugs as first-line therapy by the American Diabetes Association for all people with type 2 diabetes. So we have a whole number of these drugs that have been developed. So the very first drug in the GLP-1 class is exenatide. I did all of the mechanism of action studies with exenatide. It's a very, very good drug, but it had to be given as an injection twice a day. Not very convenient for patients. And then we had liraglutide, Victoza, once a day, exenatide once a week, dulaglutide once a week, and now these are the kingpins here. Semaglutide, this is the Novo Nordisk drug, and tirzepatide, Mounjaro, this is the Lilly drug. But I can tell you, just wait till next year. This is retatrutide. This is a triple therapy drug. So Lilly's tirzepatide drug is a combination of GLP-1 and GIP, and now we'll have the triple combination with glucagon. And retatrutide is much more powerful than is tirzepatide. And Novo has a new one called CagriSema, which is more powerful than semaglutide. And so every year we have a new set of these drugs that are coming out that are much, much more powerful. The big problem is not whether or not they work. I'll show you. They're phenomenal drugs. The problem is the cost. So these drugs in the United States cost about $1,000 per month. Per month. Times 12 months, that's $12,000 per year. So that is not affordable for many patients in the United States. Do they work? Best drugs in the world. Are they affordable? that's a different story, okay? So, what have we learned about these drugs? They very effectively lower the A1C. They're the best drugs that we have for preserving beta cell function. They inhibit glucagon, which is driving hepatocytosis production. They're the best drugs for promoting weight loss. In the United States, we have a program that's called Oprah. I don't know if you get Oprah here. She comes on in the morning, and Oprah is this big. Oprah weighs 250 pounds, and she started taking Monjaro. And every month, Oprah started looking like this, and this, and this. And then 6 months later, this was Oprah. And every person in the United States, therefore, wanted Monjaro, okay? The problem is, as I said, it's $1,000 per month. But Oprah was the best salesperson that Eli Lilly could ever have for selling a drug. All of it was free press on NBC, okay? So these drugs correct 6 of the 8 pathophysiologic problems in the ominous offset. They don't cause hypoglycemia. They have an excellent safety profile, and they are cardio-renal protective. So these are the original data with tirzepatide. You started at a low dose. You actually started 2.5 milligrams, then you go to 5 and 15. And you see here the change in A1C, it's about 2 to 2.5%. So this is a really big drop in the A1C. And semaglutide does a good job, not quite as good as tirzepatide, but still very, very good. And if we now look at change in body weight, up to 10 to 12% change in body weight, semaglutide a little bit less effective. But these drugs are very, very good. 5 kilos weight loss is great. 10 kilos even better. Drops in A1C 2%. These are the best drugs in my opinion, including people with type 2 diabetes. Now, what about the GLP-1 receptors in cardiovascular? So there have been a number of studies now in the U.S. You cannot get a drug to the market unless you do a big cardiovascular outcome study. Food and Drug Administration requires that. And as I said, the endpoint is the MACE endpoint. So as we go from left to right, it's liraglutide in the LEADER study, semaglutide, SAM6, exenatide, Excel, liraglutide, Rewind, and the hazard ratios are in the 0.7, 0.8. All of these drugs now approved in the United States for cardiovascular disease and high-risk individuals. And then most recently, we had now the SELECT study. This is another breakthrough study because this is a study done in obese, non-diabetic patients. Okay? So if you are overweight and you've had a cardiovascular event or you're at high risk, you can get into this study. And there were 17,000 non-diabetics in this study. They're non-diabetic, so their A1C is less than 50. But to get into this study, you have to have an MI, stroke, or some kind of cardiovascular event, and then you're randomized to either semaglutide or placebo, and they're followed up for upwards of 40 to 50 months. So what happened to these? So this is the primary cardiovascular composite outcome. That's the MACE endpoint. Non-fatal MI, non-fatal stroke, cardiovascular death, hazard ratio is 0.80, a 20% reduction in cardiovascular events. Of course, the drug got approved by the FDA. And then here, death from any cause, hazard ratio 0.81. So this is now a study in obese non-diabetics. So these drugs now are approved not only for treating diabetes, but they're also approved for treating obesity. If you are overweight and you had a cardiovascular event, okay, the insurance coverage will cover it. If you're overweight without a cardiovascular event, and you just want to take the drug for losing weight, the insurance company will not cover it, which means you have to pay $1,000 a month, okay? Which is okay if you're rich. But most of the people I take care of cannot afford to be paying $1,000 a month. Now, what about GLP-1 receptor agonists in the kidney? So this is the FLOW study. Now, to get into the FLOW study, you had to have diabetes, you had to have heavy proteinuria, and you had to have a reduced GFR. And then the people are going to be randomized to either semaglutide or placebo, and the endpoint is doubling of your serum creatinine, halving of your GFR, progression to end-stage renal disease, dialysis, transplantation, or having a cardiovascular event. And you can see here as you can see here hazard ratio 0.76. So here we have now that same class of drugs, not only giving you cardiovascular protection, but giving you renal protection. So this class of drugs makes you lose weight, has a huge effect on the brain. It's excellent in lowering the A1C, decreases heart attacks and strokes, and saves your kidneys. Not surprisingly, this has now become the #1 recommended class of drugs for the treatment of diabetes in the United States. So what is the problem? Okay, so you have to take the drug for the rest of your life. So once you start on the drug, it works. But once you stop the drug, I'm going to show you what happens. So here's now, this is semaglutide. I'm going to treat you for 68 weeks. Placebo doesn't do much. And with the semaglutide, you can see here that they've lost about 18% of their body weight. Incredibly effective. And now, at 68 weeks, they stop taking the drug. And look what happens. They regain the weight. And this has been observed with every one of this class of drugs. So these drugs will initially overcome the disruptive neurocircuitry in the brain that drives people to eat. But you have to be on the drug. As soon as you stop the drug, you haven't corrected the problem. The disruptive neurocircuitry is still there. You regain all of the weight. So once you start on the drug, you're going to be on it for the rest of your life. Okay? We have a different approach. We think that using this transcranial magnetic stimulation, we can actually reverse these problems on a long-term basis. But at least with regards to the medications, there's no way you can stop the drug without regaining the weight. Okay? So, what are the recommendations now of the American Diabetes Association? So, if you have type 2 diabetes and you're obese, they say that you should prioritize medicines that promote weight loss. Okay, I agree, right? But they give it a B recommendation. They should give it an A recommendation, okay? This is what is important. The preferred pharmacotherapy now should be a GLP-1 receptor agonist. The ADA has come out now and said, uncategorically, first-line therapy for an obese type 2 diabetic should be semaglutide or tirzepatide. And they tell you what the two drugs are. So this is a big advance, in my opinion, okay? Because these are the best drugs. Now, whether you can afford them, that is a very different story, okay? And one of the other big problems, which I'm not going to talk about, when you lose weight, you lose muscle mass. And so there's a big concern that with the big weight loss, there's a decrease in muscle mass, and this may lead to sarcopenia, particularly in elderly people, and this is something that's now being debated and looked at in some detail. And the other big problem is you lose weight, all the cardiovascular risk factors get better. You stop the drug, you gain back the weight, all the cardiovascular risk factors get worse. So your triglycerides go up, the HDL goes down, your blood pressure goes down. So these are wonderful drugs as long as you're on them. But once you stop, all the benefits can go away. Now, DPP-4 inhibitors, I'm not going to talk much about them. You don't use anymore. So remember, when you eat a meal, you release GLP-1. And there's an enzyme, dipeptidopeptidase 4, which is going to very quickly destroy the GLP-1. So I can block that enzyme, and I can raise the GLP-1 a little bit. Not to the level that I give you an injection. So these are really quite weak drugs compared to the GLP-1 receptor agonist. And you can see here, if data are all the same. If you're drug naive and I put you on saxagliptin, A1C drops to 0.6. If you're on glyburide, to 7. If I put you on the GLP-1 receptor agonist, I'm going to drop your A1C by 2. So these drugs are about 1/3 to 1/4 as effective, and they cost $500 a month. So there's no way I would put you on this drug for $500 a month when I can put you on a GLP-1 receptor agonist and get triple the benefit, even though it's more. Cardiovascular benefit, none. So this is the Savior trial, examined, Pecos, saxagliptin, the placebo and the treatment curves are identical, meaning no cardiovascular benefit whatsoever, and also no renal benefit. So in my opinion, you really don't have any need to be using these drugs as long as you have GLP-1 receptor agonists. So this is now going to turn gears. This is the SGLT2 inhibitor drug. So this is a class of drugs that I invented, but unfortunately didn't patent. Not very smart. Okay? This market is like a $1.5 billion market. I would never have had to write another NIH grant for the rest of my life if I had patented this class of drugs. And for those of you who know what's going on now in the United States, Mr. Trump has destroyed the National Institute of Health. So almost all funding has been cut off. So it would be nice that I had patented this drug, then I would never have to rely on the NIH. That was a brilliant idea to invent the drug, a very stupid idea not to patent. Lots of drugs in this category. So where does the story start? The story starts with a molecule called fluorescein. So what is fluorescein? Fluorescein comes from the bark of the apple trees when the apple trees bloom in the spring. And fluorescein blocks a particular transporter. It actually blocks the two transporters in the kidney that reabsorb glucose, SGLT2 and SGLT1. So you filter glucose. 90% of the glucose is reabsorbed by the SGLT2 transporter. The other 10% by the SGLT1 transporter. And fluorescein blocks both of those transporters. So back in the early 1990s, we did a series of studies in animals, diabetic animals, showing that if you took these diabetic animals and you treated them with fluorescein, and you blocked glucose reabsorption in the kidney, the diabetic animals just excreted the glucose in the urine, the blood sugar level came down. And as the blood sugar level came down, high glucose poisons your beta cells. High glucose makes your muscle resistant to insulin. So as the glucose came out in the urine and the blood sugar came down, we improved insulin secretion and we improved insulin sensitivity in muscle. And these drugs turned out to be very, very effective in treating people with type 2 diabetes. So how do these drugs work at the level of the kidney? So all of the students, I know you remember what I'm going to tell you from your renal physiology day. You probably forgot it already. True. But hopefully, this will make you remember what you should have learned. Okay? So if I would have plugged in an IV and infused glucose and raised the glucose from 100 to 180, how much glucose comes out in the urine? None. But once your glucose gets to 180, this is the threshold at which now you start to see glucosuria. And so if I keep raising your glucose, all of the glucose filtered above 180 comes out in the urine, and this is an individual who has normal glucose tolerance. It has an A1C of 5. Now what about if you're diabetic, and you're a newly diagnosed diabetic, and you have an A1C of 6.5? It's minimally increased. You can see that the renal threshold is no longer 180, it's 205. And if you're diabetic and you're poorly controlled, A1C 7.5, the threshold is even higher, and so forth. So if you have an A1C of 9.5, the threshold for spilling glucose is no longer 180, 260. So even though the diabetic has a high blood sugar and he's filtering more glucose, the glucose doesn't appear in the urine. So this is somewhat paradoxical, because as doctors, what we realize is to keep you to be dumping the glucose in the urine. So I knew about this drug called fluorescein, and it dawned on me that I could just treat diabetics with fluorescein. They would pee out the glucose in the urine, and the idea was so simple, no one ever thought about it. Okay? And I should have patented it, but I drugs now, the SGLT2 inhibitors, they block the transporter in the kidney, and by blocking the transporter in the kidney, I lower the renal threshold down to normal. So now you just simply pee out all of the glucose that's in the urine, and this is a very, very effective treatment for people with type 2 diabetes. So coming back to the ominous effect, the primary effect is on the kidney, and as the glucose goes down, and I remove glucose toxicity in the muscle, I improve insulin sensitivity, and when I get rid of the glucose toxicity at the level of the beta cells, I improve beta cells. So what about SGLT2 inhibitors in cardiovascular disease? So this was the very, very first study done with a drug called empagliflozin. And when these data were presented at the American Diabetes Association, everybody in the audience was like, whoa, okay? Because these results are incredible. So here is now the effect of empagliflozin on the MACE endpoint, MACE adverse cardiovascular event. Kaplan-Meier plot, there's 7,000 people in this study, and the hazard ratio was 0.86. There was a 14% decrease in that combined endpoint. But this is what struck everybody in the middle. Look at the effect on cardiovascular death. The hazard ratio is 0.62. This is what everybody said, wow. There was a 38% decrease in deaths. I mean, no one had ever seen anything like that before. And if we look at heart failure, the hazard ratio is 0.65. So these drugs had incredibly protective effects on the myocardium. Okay? And what's more important, you can see that the effects start within the first month. Literally, within 1 month, there was a statistically significant reduction in heart failure and death. So this was a blockbuster. And of course, these drugs now are should be, in my opinion, number 2 drug prescribed in the U.S., along with the number 3 drug, which is the nice one. Now, what about SGLT2 inhibitors in diabetic kidney disease? This is a lot of the work that I've done, and I will be getting the Barry Brenner memorial lectureship at the ADA for all this work that we've done on the kidney in about 2 weeks. So this is the Credence study with canagliflozin. So to get into the study, you had to have proteinuria and a decreased GFR. The endpoint is decreasing the proteinuria, renal death, preventing progression to dialysis patients. As you can see, with this drug, canagliflozin, the curve starts to separate 6 to 12 months, the progressively separate. Hazard ratio is 0.66, a 34% decrease in this combined renal endpoint. Dapagliflozin was the second drug that did the kidney study. And again, you can see the separation of the curves is very similar. Hazard ratio is 0.54. The Credence study was done only in diabetic patients. The dapagliflozin study, 1/3 of the patients had non-diabetic kidney disease. And the drug worked as well in non-diabetic patients as in diabetic patients. So dapagliflozin and all of these drugs now are approved for treating not only diabetic kidney disease, but for all other types of kidney disease. So this is a major, major breakthrough for nephrologists as well as diabetologists. Now, based on all these cardiovascular outcomes and renal outcome studies, the American Diabetes Association finally was forced to change their algorithm. So remember, up to about 2024, they had this archaic algorithm which said metformin to be first-line therapy, and then sulfonylurea, it totally worked. Okay? These cardiovascular renal studies, they've been going on for 10 to 15 years. But now there's so many of these studies, and they're so positive that the American Diabetes Association was literally forced to change their therapeutic algorithm. So what does the algorithm say? Now, before first-line therapy, what you used to see here was metformin. So now, they take the metformin out. And it says first-line therapy. And then you have to go down. If you have diabetes and atherosclerosis, you should be on a GLP-1 receptor agonist or an SGLT2 inhibitor. If you have heart failure, you should be on SGLT2 inhibitor. If you have diabetes and renal disease, you should be on an SGLT2 inhibitor. And of course, this is the correct algorithm. I think no one would disagree with this. So what is the real problem? The real problem is only 16 to 20% of our patients have cardiovascular disease or renal disease. So what are we going to do with the other 80% of the patients who have diabetes and they don't have cardiovascular or renal disease? These drugs, SGLT2 inhibitors, GLP-1 agonists, where do they fit in the algorithm? So this is the ADA algorithm, okay? I'm going to put something up there in a second. So I'm going to ask you, they changed. So what drug have they moved up on the left? And what drug have they moved down on the right? The goal is still A1C7. Okay. So on the left now, finally, they said everybody, GLP-1 should be first. Okay? Good. I like it. And then to the right, of course, they moved down DPP-4 inhibitors. Because if you're on a GLP-1, you shouldn't be on these drugs. Okay? They're not going to add anything. Now the problem is they give equal credence to all of these drugs. They say if you are a newly diagnosed diabetic patient, you can put someone on insulin, metformin, SGLT, SU, CCD. To me, this doesn't make any sense at all. Okay. First, if I had a newly diagnosed type 2 diabetic patient, I wouldn't be starting them on insulin therapy. Okay. Insulin therapy is not easy for diabetics. And by the way, it's very expensive. And for sure, these drugs, sulfonylureas, you can take them off the market. Okay? They shouldn't be in the first line. So metformin is reasonable, SGLT2, PCD are reasonable. But now we have more things to think about. Diabetes is a whole body disease. It doesn't just affect one organ. So when we're picking a drug to treat our diabetic patients, of course, we want to lower the A1C. We want to control the glucose. But our patients have a lot of cardiovascular disease. So we would like the drug to give you cardiovascular protection. The majority of people are overweight. So we would like the drug to promote weight loss. We also know we have this new world disease, MASH, MASH. Every year they change. It used to be NASH, then it became MASH. Next year, who knows what the name of it will be. But this is steatohepatitis, fibrosis in the liver, and then chronic kidney disease. So this is what our diabetic patients look like. They don't have just glucose problems or a kidney problem. So when we pick a drug, we need to correct all of these problems. And that also is telling us we need to be thinking about drugs in combination. So I'm going to show you two combination studies and then finish with a large study that we just published in Semineri. So this is the duration 8 study. In duration 8, 1/3 of the people got treated with dapagliflozin. So this is an SGLT2 inhibitor. 1/3 of the people got treated with exenatide, this GLP-1 receptor agonist, and 1/3 of the people got the combination. Dapagliflozin lowered the A1C by 1. Exenatide by 1.3. And when you put the two together, 1.7. So you clearly get an additive effect. Okay? So this is good, but this is even better. So now, this is the cardiovascular endpoint. So this is myocardial stroke, peripheral vascular disease, etc. So what I'm going to do, I'm going to compare if you're on dapagliflozin versus DAPA plus empagliflozin, or empagliflozin versus the two. So you can see, if you are taking the two drugs, dapagliflozin and empagliflozin, the hazard ratio is 0.76, meaning you have a 24% lower likelihood of having a heart attack, a stroke, or dying, compared to if you're taking either drug alone. If I put you on the two drugs together, the hazard ratio for myocardial infarction is 0.71. That means you have a 29% lower chance of having a heart attack if you're on both compared to one. And then the last one, which is all-cause death, either being dead or alive. Okay? If you're on both of them, you have a 32% greater chance of being alive than if you're on either one alone. Again, coming back to the fact that you should be using drugs in combination that have additive or synergistic effects. Okay? Now, this is a study that is recently published from the Taiwan National Health Insurance. So in Taiwan, the medical history of every single person was on a big national database. And so what these investigators did, they went into this database and they're going to look at all-cause mortality and cardiovascular mortality in people who are treated with a GLP-1 receptor agonist, which is yellow, or people who are treated with pioglitazone, which is the white line, or people who are treated with GLP-1 and pioglitazone. And the control group is you could be treated with any other drug other than GLP-1 or pioglitazone. So you could be on metformin, sulfonylurea, DPP. So these are the non-users. And this is the cumulative incidence of death. Here is GLP-1RA. So they're good. They're less likely to die. Here's pioglitazone. It did twice as good. And if you put the two together, it did twice as good as either one alone. Okay? And if you look at cardiovascular mortality, you see exactly the same thing. GLP-1, pioglitazone, and pioglitazone plus GLP-1. So again, combination, and these are my three favorite drugs. Now, we decided that we would do the definitive study. And the last 5 or 6 slides we're going to go ahead and this is called the EDIC study. And Dr. Kanat was in San Antonio when we were doing these studies, and he was involved in the work. And what we wanted to do was to take the ADA algorithm and compare it to the DeFronzo Abdulani algorithm. Okay? So this is a very large study, 318 people, and they were divided into 2 groups. So one group got the ADA effect. I start you on metformin, and when you fail, your A1C will come down, and then it'll go up. You fail. Guaranteed. And then I add glucagon. Your A1C will go down, and then it'll go up. You'll fail. And then we'll add glargine. Okay? And then the other group got metformin, pioglitazone, and exenatide from the beginning. So at the time we did this study, we had this old-time GLP. We didn't have tirzepatide, or we didn't have Ozempic. This is an old guy, okay? And we didn't have the SGLT2 inhibitors. They hadn't come on the market. We had metformin. So this is an old-time study. But I'm going to show you the old-time study totally destroyed the ADA effect, okay? So the endpoint was the percentage of people who after 3 years had an A1C less than 6.5. Okay? The endpoint is not the A1C, because once your A1C got to 6.5, you were out of the study. So the A1C couldn't go very high. So what we wanted to know is what percentage of people would, at the end of the study, have an A1C less than 6.5. Okay? And in fact, I'm going to show you the 6-year data. Okay? So they start with an A1C of 8.8. So this is the ADA approach in yellow. And at the end of 6 years, the A1C is 6.9. But remember, the A1C can't go very high because once you get to 6.5, you're thrown out of the study. Man, okay? But we still did much better with our triple therapy. So this is the endpoint, the real endpoint of the study. If you got the conventional therapy, okay, 72 months, 6 years later, okay, 29% of the people had failed. No, wrong. 71% of the people had failed. Okay? Just to make sure you understand that. So if you went on to the AD approach, it was virtually guaranteed that you were going to fail. Now, if you were in our triple therapy, 70% of the people actually were well controlled at 6 years. This difference is like night and day. This is total destruction of the ADA algorithm. And you can see this is highly statistically significant. So why did this happen? Why there was such a dramatic difference? Because remember, I told you when it started to talk that all my life I've been interested in understanding what causes disease, and that if you will use the drugs to correct the underlying pathophysiology, you will be successful. So here now, this is our triple therapy. This is insulin sensitivity using a used glycemic insulin plant to infuse insulin, radio-labeled glucose, and measure glucose uptake in the muscle. This is the gold standard everywhere in the world. Look what happened. We tripled your insulin sensitivity. I normalized your insulin sensitivity. What happened with the ADA? Absolutely nothing. Metformin, sulfonylurea, insulin did not improve insulin sensitivity whatsoever. What about your beta cell function? This is our triple therapy. I just gave you a normal beta. So someone asked me earlier, do we have a cure for diabetes? This is about as damn close to a cure as you're going to get. And remember, we're using these old drugs, not the new ones. We're not using Ozempic and Mounjaro. We're using exenatide. We're not using the SGLT2 inhibitors. We're using metformin. And what happens if insulin secretion in the conventional therapy? Absolutely nothing. Now, big cardiovascular outcome studies, they recruit 5,000 to 10,000 people. As I told you, we had 318 people in the study. So we measured carotid intermediate thickness, which is a surrogate measure of cardiovascular. Here's progression of carotid intermediate thickness in the conventional therapy with no progression in the triple therapy. So, last slide. What is the algorithm you should be using? Okay, so Dr. Abdulghani was going to be here, and he comes every year to this meeting in Boulder, but has a family illness. I call this the DeFronzo Abdulghani algorithm. This is the right one. The ADA is not the right algorithm. Okay, so what is the drug you should be using? There are 4 good drugs. When I give a talk, I'm happy if I can convert you to start therapy with 2. If you start therapy with 3, I think I'd have died and gone to heaven. Okay? I probably am not going to heaven anyway. But use 2. If you really get the message, use 3. So which one do you want to use? I don't care. I just want you to get started on using multiple drugs. Okay? Now, metformin is very cheap. $5. Feel-good-is-not is very cheap. So even if you pick those 2, the cost is not an issue. Okay? These other drugs, of course, are much more expensive. And why these drugs? Because these are the drugs that really correct the cardiometabolic renal problem. They're good for protecting heart attack and stroke. They save your kidneys. They lower the glucose, and they protect against eye, kidney, and nerve damage. So that's the last slide that I was going to present. So I want to thank everybody for staying put and listening. And I don't know if you want to do time for questions, but I'm here.
Dr. Franzo, we sincerely thank you for sharing such valuable insight with us today. We are truly grateful for your time and contribution. Thank you.
Okay.
Şimdi salondan varsa soruları alalım. We will now open the floor for questions.
Young lady in the front.
Thank you for this spectacular talk. I just wonder, have you ever measured the sex differences in your research? How the difference in the drug response in women and men? And do you plan to use the combination of these 4 drugs and check how women are going to respond to different combination or men?
Yeah, so we have never noticed any significant difference in sex difference in the responses to these drugs. In animal studies, however, and I think this is where some of the controversy comes from, in animal studies, there's oftentimes a difference from male to female. people, men and women generally respond very similar to the drug. We don't see big effects difference.
Thank you so much.
Yeah. Everybody is overwhelmed or embarrassed to ask questions. Yeah. Yeah. So I had a series of slides that I took out. The newer GLP-1 receptor agonists have been used to treat alcoholism and very effective. They're used to treat drug abuse, actually with modest effects. They're also used to treat psychiatric disturbances, depression, schizophrenia, a lot of issues in this. And at our institution, we have a big Alzheimer's, one of the biggest Alzheimer's centers in the world. And we have a number of studies that are going on using the new GLP-1 in Alzheimer's disease. So there's a lot of interest in not only diabetes, but other types of CNS-related disorders. The Alzheimer's disease, as you can imagine, is a more long-term study. But we'll see. Some of the data is pretty good. Yes.
I was going to thank you for this high informative presentation. I was wondering about a more social stance from you. I was wondering if you could manage to achieve a higher success rate if you manage to generate more ways for the general public to have greater access to a generally more healthier lifestyle.
Yeah.
Because I think that's most of the times that's the root of the problem. So we didn't get as far as you said so many medications.
Yeah. So that's a good question. So when you lose weight, and you're losing enormous amounts of weight, and people are losing up to 20, 25% of their body weight now. So what happens now, as they lose weight, they're physically more trim. These drugs also make you feel better. And so they tend to get more involved in social activities. They go to the gym and they work out more. So it has a big effect on the whole social profile. And quite frankly, being overweight is stigmatized in society. And when people lose weight, they feel better about their body image and they integrate more in social activities. So that's a whole, I personally, that's not an area of research that I'm involved with, but it's an intensive area of research. These drugs actually do give people a better self-esteem, and they get more involved in all kinds of social activities. That's a big part of it.
I know that it's a problem and for the information and that, but what is your stand? Because if I understand you right after that, what is your stand about this lifestyle? Yes, the drugs and that the drug diet, for example. What is your first goal? Like starting the medication and what is your stand towards your lifestyle change?
So you're not going to like this question. You're not going to like my answer. Because the answer is well known. Okay? There are over 200 lifestyle intervention studies. And you know how many failures there are? 200. Okay? So it is very, very, very straightforward. On a long-term basis, lifestyle does not work. That can be said uncategorically, and if you think otherwise, you can put more people. Okay? So that's on a long-term basis. On a short-term basis, lifestyle intervention is the best intervention that we have, and it works. Okay, so if you can get people to lose weight and exercise 3 times a week, all of these bad metabolic factors, they all get better. That's very, very well accepted. The problem is, if you look at long-term, after 3 years, virtually everybody is impaired. And there are reasons for that. Maybe next year I can come back and tell you but you're delusional because people work in long information. But you simply don't know what's in the news. There are over 200 studies almost. Okay? There are a few exceptions to what I just said, but in general they all fit. Okay? Does that mean lifestyle is not important? It's critically important. Okay? But even if I can't get people to lose weight, I need to prevent them from gaining. Okay? So if the lifestyle intervention actually keeps them from gaining weight, I feel I'm successful. Okay? If they lose weight, and about 10% of people will lose weight and keep it off for a long-term basis. The other 90% are going to fail. I mean, that's what's out there. And you can try all kinds of lifestyle. And those numbers that I gave you, they're rock solid. Okay? So we actually have a very, very active lifestyle program. In the Texas Diabetes Institute, we have a gym, we have nutrition therapy. All of our patients participate in the program. We have 3 dietitians, and all of our patients, we can go to a 10-hour dietetic course. They need to be able to go to the local grocery store and shop, and they need to bring the food back to the kitchen, and they need to cook the food in the house. So we are very aggressive, but we're also realistic. Okay, so we start the lifestyle implementation.
I have a question. Do you believe counting diet works?
I know you're somewhere. I can't see it.
Do you believe that counting food is actually works on diet, but counting carbon food and everything on the menu or maybe fruit, does it work best or whatever?
Yeah, so I guess you're asking me what type of particular food stuffs are best. Okay, so in my opinion, there are only 2 things that are important. Scientists don't like to eat them. Okay, the most important thing is calories in and calories out. Okay, if you maintain your body weight, that's the best thing you can do. If you gain weight, that's a total disaster. So what determines weight gain? The number of calories you take in compared to how many calories you go out. So gaining weight is a disaster for diabetic patients. Now, if you look at the ADA dietary recommendations, they actually don't specify anything about what the content of the food should be. And what they say is that you should talk to the patient and you need to develop a dietary intervention that's compatible with the patient's lifestyle. So if you try to put the person on a dietary intake or a dietary regimen or a composition that's different from what the patient normally takes, you fail all the time. So what you need to do is decide what does the patient do. Do they eat 2 times a day, 3 times a day, 1 time a day, and work with that. The only big disaster about diets, in my opinion, is if you put them on polyunsaturated high-fat diet with a lot of cholesterol, you're looking at a heart attack. So if I can control 2 things, it's the calories and the cholesterol fat content in the diet. Now, if you are a type 2 diabetic, the other thing you have to be careful about is simple sugar. Okay? This concept that fruit and simple sugars are good, that is not correct. So you start drinking orange juice, and your glucose is going to shoot up. Okay? People don't recognize that fruit have a lot of simple sugar, and that is not something you want to have diabetic pleasure. In fact, if you are diabetic and you have low glucose, we tell you to take a glass of orange. Why? Because it has a lot of sugar in it. Yes, we talk a lot about food and stuff. If you are a non-diabetic and your normal weight, probably doesn't make too much difference what you eat. But if you're a diabetic, then you have to be very careful that you don't have to sit. You don't want a lot of fat in the diet. And most important, more important than anything else in the world, you cannot gain weight. If you gain weight, you become very insulin resistant, you get negative cancer. That's the biggest disaster in the world for diabetes. And of course, weight control is Okay, so Mustafa and I'm going to diverge. I'll tell you what I'm talking about next. I decided that I would look and see what these people in the obesity field are doing and what they know. And what I decided, they don't know anything, and everything they're doing is completely wrong. So I'm a reasonably intelligent guy. My area is diabetes. So I said, well, I'll just look and see what they're doing as someone who's not in the field. And it was very clear to me, they actually don't know anything. And what they're doing is completely wrong. So if you read and you hear lectures given by people who give obesity lectures, they all focus on the hypothalamus. Okay, the very first paper looking at the hypothalamus was a paper that I published in the year 2000 by a Japanese scholar. So I have an interest in hypothalamus. That is absolutely not where the problem is. Okay? The problem is not in the appetite centers in the hypothalamus. The problem is in the hedonic areas in the brain. And those are the hedonic areas in the brain that tell you how food appears. And it over-accentuates visual cues. So this is the prefrontal cortex, the amygdala, the pituitary. So when people look at food, the food looks good and they overeat. And that's got nothing to do with what's going on in the hypothalamus. So in the hypothalamus, you get cues that are coming in, and the hypothalamus regulates energy based upon what your normal weight should be. So let's say you're 5'8", you're supposed to weigh 160 pounds. The hypothalamus says you have to take in a certain number of calories to keep your weight at 160 pounds. Okay? That got nothing to do with why you gain weight. It's all those other areas in the brain that are looking at food cues and telling you how to interpret them, which are telling you to overeat. Okay? So you have to do something about those areas in the brain. So what do we know about those areas in the brain? There's a marked decrease in the gray matter area and all of those hedonic areas in the brain. And strangely enough, the brain doesn't respond to insulin. But in obese people, in those gray areas of the brain, that part of the brain becomes hyper-responsive to insulin. The major changes in the metabolism and the neural circuitry of the brain becomes very disrupted. So when you eat, okay, there's a signal, there's certain areas in the brain that light up. And then they send the signal in different areas of the brain. And those circuits get messed up in people who are overweight. Now, if I treat you with a GLP-1 receptor agonist, this is like I come in with a sledgehammer and I pound your head and I beat you into submission, okay? And I can force you to stop eating, okay? But what happens as soon as you stop the drug, okay? You regain back all of the weight. Why? Because the gray matter in the area in the brain has not re-expanded. The change in insulin sensitivity in the brain has not changed, okay? And so as soon as you go off the drug, you start eating again, and you regain all of the weight, and the neural circuitry is not correct. So we've taken a whole different approach, and we have built a coil. It's a magnetic coil that the person can wear. So if you tear up your knee, if you're an athlete, you rip up your knee, and you tear the cruciate or whatever, they put you in one of these long tubes, and they take a picture of your knee by bouncing magnetic waves off. So we took the same magnetic sort of approach, and we built a coil, and the person sits in a chair, and they're going to be treated for 5 weeks, Monday, Wednesday, Friday, for 30 weeks. 1 week, Monday, Wednesday, Friday, 30 weeks. Next week, Monday, Wednesday, Friday, 30 weeks. And then 1 year, now they've only been treated for 5 weeks. 1 year later, they lost 10.8 kilos. And we went against Ozempic, and Ozempic lost 7.8 kilos. When you stop the Ozempic, you regain all of the weight. The people treated with TMS, they've been not treated for 11 months. And they still lost 10.8 kilos. So what does the TMS do? It restores 61, okay, the neurosurgery goes back to the way it was up before. Right? So when you try to get people to lose weight by diet, nothing changes in the brain. Okay? And so now the person who is losing weight, he has to outthink their brain. You're going to lose on a long-term basis. On a short-term basis, when you're going to see the dietitian or you're in class and you're doing this 3 times a week and you're faithful for it, it works. Okay? But 3 years later, maybe you're not so good at maintaining the diet and the exercise. And what happens? You regain the weight. So I think we need to take a new look at how we need to approach obesity. These drugs are wonderful, but if you have to take a drug that costs $1,000 a month for the rest of your life, that's a problem. And remember, childhood obesity always ends up with adulthood obesity. So if you have a 16-year-old kid who's this big, are you going to put them on Ozempic? And they're going to take Ozempic until they're 90 years of age? So this is a public health problem. Can we afford it? And how should we be approaching or maybe the restructuring the brain, CMS would be a different, maybe next year when I come back.
Thank
All right?
you. Thank you so much.
Okay.
Yeah, please stay stage here. Yeah, we are truly grateful for your time and contributions. And before we let DeFronzo leave the stage, we will proceed to plaque presentation.
Oh.
Yeah. Katkıları için bir kez daha Doktor DeFronzo'ya teşekkür ediyor. Takdimleri gerçekleştiren hocalarımıza. Şimdi takdimlerini gerçekleştirmek için sahneye davet etmek istiyorum. Sayın Tıp Fakültesi Dekanımız Sayın Profesör Doktor Faruk Aydın'ı ve Profesör Doktor Mustafa Kanat'ı sahneye davet ediyorum. Tüm katılımcılara değerli katkıları ve ilgileri için teşekkür ederiz. Şimdi çay kahve ikramı için 15 dakikalık ara veriyoruz. Daha sonra bilimsel çalışma grubunun değerlendirme toplantısı ile programımız devam edecek. Başa.